SNRI, whatever, it's slowly tapered over 4 to 6 months. Okay, so now just think about it. You have a person with panic disorder, they're placed on an SSRI, takes 3 months, 12 weeks to work. Let's say it does work on the best optimal cases. Keep them on it for 24 months. How long is that? That's almost over 2 years, right? And then you're going to withdraw them over the next 4 to 6 months. You're talking to almost a 3-year therapeutic regimen for the first episode for panic disorder. And the reason why you taper them so slowly, because, again, as I mentioned, this stuff gets pretty hardwired. They could relapse or rebound quite easily. And so you don't want to withdraw them quickly, but you want to make sure you can reinstate treatment very quickly. And then even use benzodiazepine if you had to. Okay? The other aspect is what happens when you have someone on an SSRI for 24 months and you suddenly stopped it. You get what? You get the SSRI withdrawal, the flu-like syndrome and all that sort of thing. So you can't forget that. Okay? And then, of course, you monitor. All right. Any questions on panic? See, that wasn't too hard, was it? Anything there? Okay, so let's look to today's last topic, the social anxiety disorder. Here, the goal of therapy is to reduce physiological symptoms and phobic avoidance. Okay? So, for example, a person who doesn't like to perform, you have to get them slowly ingrained to it, not to avoid it. Some things you can't avoid. To me, one of the best ways to do performance anxiety is sometimes, well, you know, it's kind of one of those non-pharmacologic things, even though is money. Money is a powerful reward mechanism, okay? So, for example, if you have a problem public speaking, what would you do? You could practice it, right? If someone paid you $20,000 for a 30-minute talk, wouldn't you work at it to overcome your anxiety? Not enough? How about $50,000? Now you do it. There you go. So those are the things to think about, okay? So and the case example would be me. I had problems in public speaking early in my career. You wouldn't think about it, but it really took me a while to do it. Little things used to bother me, like this falling down, I'd freeze and didn't know what to say. But after a while, like for example, when I was involved in launching a new drug, and talk about performance anxiety along the way, I had a drug company say, Mike, we'd like you to come up and do a presentation for all our national sales rep in Chicago. I'm going on vacation next week. We know it's a last-minute thing. You know, my mom's flying in from L.A. You know, we're going to go down to Orlando. We've got airline tickets. And the guy says, okay, Mike, we really want you bad. We'll triple your fee. Really? We'll have a limo waiting for you at the airport. Whisk us up to our headquarters. You do your 1-hour lunch talk. We'll whisk you to the airport. We'll have you back home by dinner, and you'll make your flight. I'm there. Thank you. Hey, I got over that real quick. So those are the things you think about. So you can really work at it from a lot of different ways for this, okay? Now, you look at, once they respond, you look at continuation phase, meaning that they have to be continually doing this. So I would practice talking to the mirror. I know it sounds funny, but people do that. That's okay. So that's how and you keep doing that for several months, okay? Keeping in mind, when they really have this, you have to also do maintenance therapy. You really have to address it also very aggressively. And again, like a lot of other anxiety disorders, psychotherapy and drugs work together. I didn't need talking to a psychologist. That's what happens when you do this for a living, that kind of thing. So we're good at that, okay? And again, keeping in mind also, if patients are on these medications, there's a chance for relapse, and they have to be monitored for that. And I've put some time frames for you. And therapy, back to our good old friends, antidepressants. Same rules apply. Your textbook runs you through them again, that kind of stuff. There's nothing different about them. Now, unlike panic disorder, unlike generalized anxiety disorder, tricyclics do not work for social anxiety disorder. So if you want to bold that one, that's okay. Tricyclics do not work for social anxiety disorder. Okay? And let's go through the quick therapeutic algorithm in your textbook. Again, it's really simplified for you. If the diagnosis is made, you put them on an SSRI or SNRI. I love it. It's the same drugs. 12 weeks. Now, response. There's your three points here. This is actually more realistic. Response could be 6 to 12 months. So this is more like a depression model. Shorter than panic, right? Panic can go up to 24. This is shorter if they get an excellent response. More often or not, there's a partial response. That's where it becomes gray. Then the question is, do you switch or do you keep? Again, you could titrate the dose to maximum for tolerability. So those are things you think about. And then the challenge here is if you have partial response, you have to think about augmentation. And the choices they give here in your textbook are buspirone or clonazepam. I like buspirone a little better. The reason for that is clonazepam could cause all those dependent sedation bad things, right? So buspirone's a little bit better. If it's with an SSRI, SNRI, you're both mucking with serotonin. You have to watch out for serotonin syndrome, even though it's extremely rare. All you need is one to sue you. Okay? That sort of thing. Then no response, then you switch from one class to another. It's the same rules. Okay? And then your thing here says, if no response to an SNRI or SSRI, switch to phenelazine, back to the MAOI. And again, that's more for historical purposes. I don't know of any psychiatrists that do that today. Okay? And then you see non-response, you rear its ugly head again, pregabalin or gabapentin comes in off-label. Okay, special populations. This is where social anxiety is present often if it occurs in young children. You wouldn't think about that, but yeah, it does from epidemiological data. And like a class label warning, if you're using an antidepressant, you got to watch out for the suicidal ideation. You would not want to use benzodiazepines for kids. Just think about that. But you could see that. It depends on the young children. They get exposed to alcohol. They have to be careful with that. And at the same time, they don't want to use MAOIs. Oops, I inverted my O and my A. So benzos can be used. It just has to be really, really careful. SNRIs, as mentioned, can be used. This is something that your textbook mentions that there are case reports for. Mirtazapine, 30 milligrams used in women, effective over 10 weeks. It has this one little blurb in there from case reports. So I guess the bottom line is don't be surprised if you see mirtazapine there. Okay? Benzos, again, are also reserved who cannot use or tolerate SNRIs, SSRIs. Gabapentin, off-label, but it reported to be effective. Now, this is kind of interesting. This is based upon historical data. Beta blockers. How many of you heard of taking a beta blocker like propranolol just to calm you down before you do something? All right. That's for your heart rate. Doesn't do anything for the psychic worry. Okay? So, and the studies do show that as well. People actually study that. Little low dose propranolol. Well, okay, but doesn't really do a whole lot, but okay. That sort of thing. And shouldn't use it, obviously, every day. So, it's one of those things to think about. Okay? Clinical controversy. Again, this is where for social anxiety disorders, it's a little bit more not as clear-cut. Because social anxiety disorder are what? Situationally. So the question is, how can you get them more exposed to the situation in a systematic fashion? Again, that's where psychologists can really perhaps design a patient-specific program to help with that. Okay? So Think about that. So, a person gets really nervous about going out to an event. Let's say a person gets really nervous and anxious going to a Cowboy game at AT&T. They can't stand the crowds. They get real nervous, all that kind of stuff. And, they ultimately give away their ticket. Anybody want a Cowboy ticket? That kind of thing. Wow. Well, what do? Do you want to know if it's the Cowboys, or do you want to know it's the event, or going to football? How about sending them to a high school football team? To a smaller stadium, not these 10,000-seat high school games. Send them to a smaller stadium if it's that sort of thing. That's how you work on it. Or send them to a college game that doesn't have a whole lot of attendance. That sort of thing. That's how you do that. Okay? And then you have to work on a weekly basis, sort of thing. That's how you work with social anxiety disorder, with cognitive behavioral therapy. Okay? All right. Case, and then we're done. JM, Caucasian male, seen in emergency department. I think I have a serious heart condition. 4-month history of episodic events, which, have increased recently. Feelings of smothering sensation, trembling, lightheadedness, shortness of breath, heart pounding. Past history of migraine. Can't forget how migraine. 2 to 3 times per month for 10 years. Mother has a history